Okay, hey everyone. This is Eric Feuchtbaum. It's nice to have you all here. I think there's quite a few of you in the room today. Give me 1 second. We're just trying to get this to load up. Okay, here we go. So again, just to introduce myself, I'm Eric Feuchtbaum. I'm an orthopedic spine surgeon with Aligned Orthopedics. And I know this is late in the evening, but we've got, I think, 300 of you joining us today. So I really want to thank you all for being here. I really appreciate you all listening in on how we can improve our spine. So just a little background about myself. I went to undergrad at Brown University. I've kind of been all over for my training. Went to the University of Virginia School of Medicine for medical school. Then took a short trip for 5 years to the Midwest for my internship and residency at WashU in St. Louis, and then moved back to New York for my fellowship at the Hospital for Special Surgery in adult and pediatric spinal surgery. And then after the birth of our first child, my wife and I decided to move back to Virginia to be close to family. As you know, how much families can help with taking care of your children. So today's discussion is going to be about, sorry, I'm just moving the bar out of the way, osteoarthritis of the spine. And this is a pretty large topic to discuss in about an hour or 45 minutes, leaving some room for questions. So I hope you can bear with me. We'll try to keep the term simple and explain things as clearly as we can. Again, because there's so much to talk about here, we're going to hit high points, and we're not going to be talking about things like fractures or tumors or disc herniations, strictly osteoarthritis of the spine. So we'll go ahead and get started. So let's discuss what is arthritis in the first place. And you may have joined some of the other talks where they discussed it, but arthritis is a wearing away of the mobile sections of our body, which are joints. So it can affect all body parts, such as the hips and knees and shoulders. And of course, it can affect the spine as well. For other joints, such as the hips and knees and shoulders, the primary complaints of osteoarthritis in these joints are of pain and stiffness as the main complaints. However, with arthritis of the spine, the symptoms are a little bit different. They can include pain and stiffness, but more importantly, they can lead to symptoms of neurological compression, such as pain radiating down the arms and legs with numbness, tingling, and weakness, or sometimes lead to other neurological problems, such as imbalance, trouble walking, or trouble with bowel and bladder function. Osteoarthritis in general comes in two forms. One is osteoarthritis, which is the age-related degeneration. That is as a result of getting older and being subjected to gravity, playing sports, exercising, and traumas that build up over the years. And then there's the inflammatory or autoimmune type of arthritis, which include those such as rheumatoid arthritis, which we'll not be discussing in that much detail today. So arthritis can affect all areas of the spine, including the cervical, the neck, the thoracic, which is the mid-back, and the lumbar, which is the lower back. Arthritis preferentially affects the cervical and lumbar spines because these are the most mobile sections of your spine. The cervical spine is responsible for giving motion to your head, and the lumbar spine in conjunction to your hips are responsible for allowing you to bend through your pelvis and your hips. So because these areas are subjected to more forces and more motion-related forces, they're more prone to osteoarthritis. In comparison, the thoracic spine, which is stabilized by our large rib cages, are relatively immobile. So you don't see as much osteoarthritis within the thoracic spine. I hope my mouse is projecting to you all, but I want to turn your attention to this picture here. This is what the osteoarthritic spine looks like. And a lot of our topic about surgery or non-surgical techniques kind of depends on understanding a little bit of the anatomy here. So when arthritis affects the spine, it affects two primary areas. The first is the disc. The disc is the cushion that separates the vertebrae and gives the body or the spine its motion, and it also serves as a shock absorber. In addition, there's a joint called the facet joint, which is this structure here. This structure connects one vertebrae to the other posteriorly or along the portion of your back. And arthritis can affect the cartilage in both of these areas. What happens as the disc degenerates and the facet joint degenerates, the vertebral body height gets smaller. So the space between the vertebrae gets smaller. When the vertebral body height or the interdiscal space gets smaller because the disc is wearing away and the facet joint wears away, the spinal canal shrinks. And as a result, it creates narrowing of the spinal canal, or a condition called stenosis. Stenosis, you probably have heard of, is referring to narrowing or compression in a certain area. And in this topic, it's the spine, of course. So the vertebral bodies getting closer together, or loss of integral height, creates narrowing of the spinal canal. But also, like in your hips and knees and shoulders, you can get bone spurs. So degeneration of the facet joint in the disc creates bone spurs. These bone spurs can intrude on the spinal canal, and in conjunction with the loss of the height, the bone spurs and a narrowed spinal canal can cause compression of nerve roots or spinal elements such as the spinal cord. And this is what creates symptoms of sciatica or radiculopathy, which are symptoms of pain radiating down the legs or the arms associated with numbness and tingling or weakness. So spinal conditions with neurological problems are often more treated with surgery rather than spinal conditions where the main symptom is just of neck and back pain without a neurological problem with the arms and the legs. So these are two examples of osteoarthritis. These are two images. The one on the left is an MRI sagittal view of the cervical spine or the neck. The sagittal view is essentially a side profile view, and the image on the right is a sagittal or side profile view of the lumbar spine. If you turn your attention to the MRI in this picture, again, I really hope the mouse is projecting, but this is the C23 disc. This is a relatively healthy, tall disc. And as you can see, this area here in the middle is the spinal canal. The structure in gray running down the middle of the canal is the spinal cord. The structure surrounding it, which is this really bright white substance, is the spinal fluid. So we can see this area is large and wide open because the disc is not degenerated and the disc is still tall. Similarly, down here, this is the C7T1 segment. The disc is relatively intact. The disc is quite tall. And you can see the spinal column or spinal canal is still quite capacious or large in this area. However, these four discs, which are the C3-4, the C4-5, C5-6, and C6-7 levels, you can see the disc is much smaller. So as a result of the disc getting smaller, the vertebral bodies are getting closer together and the vertebral column height shrinks. The combination of the vertebral body column shrinking and these little dark protrusions or bone spurs, the combination of these two are creating narrowing of the spinal canal. So you don't need to be a trained radiologist to realize the spinal canal right here is quite large and open. And in the areas where the disc is degenerating because of arthritis and where bone spurs have formed, this is a bone spur, this is a bone spur, there's a kinking at each of these levels or compression of the spinal elements. So again, the concept of arthritis is that it makes joints stiff and creates pain, but in the spine, the loss of height between vertebrae creates narrowing of the spinal canal, and bone spurs in combination with the narrowing create compression of spinal elements. And this is, again, really important to some of the surgical discussion we're talking about later. So not to sound like a broken record, just to kind of hit home, the collapse of the disc, the wearing away of the disc shortens the spinal column, which creates stenosis or pressure, and the arthritis itself creates bone spurs, which in combination of that narrowing of the spinal canal creates even more pressure. So I am a big believer of conservative treatment for spinal conditions. I think a vast majority of patients can be treated for their arthritic spine conditions with conservative management, such as physical therapy, nonsteroidal use, and anesthetic blocks. It's a much smaller percentage of patients who end up needing surgery. At least in my practice, surgery should be the last option or the last rung on the ladder for the patient before considering surgery. They should undergo significant conservative treatment. So I'm a big believer in physical therapy. We'll talk a little bit about that. The Academy of Orthopedic Surgeons recommends nonsteroidal use for treatment of osteoarthritic conditions, not only in the spine, but in the rest of the appendicular skeleton, such as the joints within the arms and the legs. And of course, anesthetic blocks and injections can be a substantial adjunctive treatment to some of these other measures we're talking about. One thing you'll not see that we'll talk about today is the use of stem cells, PRP, or other biologics. And the reason for that is they're not well studied in the spine yet. I do think in the future, it might be the very near future, as we have a better understanding of these new technologies that can be regenerative in some cases. These will be a mainstay treatment for spinal conditions, but I think our knowledge and understanding of how to apply these technologies to the current landscape of arthritic conditions of the spine is a little bit lacking. So we're not going to talk about this as much. I do think patients who are interested in seeking these types of treatments should speak to a respected and reputable doc who provides these procedures, usually a pain management doctor. And again, I'm always happy to have conversations with the patients seeking these types of treatments and refer you to a doc who I think is, reputable and is not going to steer you in the wrong direction if considering these types of treatments. So again, physical therapy, a very strong mainstay in the treatment of my patients. The whole idea here is to strengthen the core and the postural muscles in the back and improve the posture to support the spine. So I actually think of physical therapy as two separate phases. The first phase in a patient who's having pain should be using physical therapy for pain relief. So this might include gentle manipulations, it might include dry needling, it might include massage. However, the second phase of treating should be working on strengthening the structures that support the arthritic spine. And that's getting your core stronger and getting the postural muscles that support the neck and back stronger. Some of you may have seen me and might have heard me say this, but you can think about what does you do if you wear a brace externally on your spine. And a brace is very supportive. It lets the spine relax. It provides pain relief by support and comfort. But if you think about it, the back muscles or your postural muscles, your core abdominals, such as the rectus abdominis, which lives in the front of your abdomen, and the obliques, which live along the side, they all surround your spine and serve as your own personal internal brace. So I think one way of thinking about treating neck and back conditions from arthritis with physical therapy is to strengthen your internal brace. Get those muscles as strong and flexible as possible to stabilize your arthritic spine. And I think that's a really valuable way to avoid needing to take medications, get injections, or eventually have surgery. Non-steroidal medications, there's several of these. There's the over-the-counters, as you can see in this picture, such as Motrin or ibuprofen, or Aleve, which is naproxen. And then, of course, there's several prescription medications you may have heard of, such as the diclofenacs, the Mobix, and the Celebrex. These medications, in my opinion, are not for chronic daily use. I think they're better suited to be used in higher doses for short spurts. Get the medication in the bloodstream at a high enough concentration so they can have their anti-inflammatory effect. You get better improvement from pain relief. Maybe the therapist can do a little bit more with you, but they're certainly not to be used in a chronic nature unless you've got sort of clearance from this by your primary care doctor. The reason is these medications can have detrimental effects on your gastrointestinal tract and can lead to reflux or ulcers. They can lead to blood thinning and easy bruising or bleeding. And in chronic use, they can cause kidney injury. So if you are on a blood thinner or you have a history of ulceration, if you have an allergy to these medications, or you have a history of chronic kidney disease or kidney injury, it's probably best to avoid these medications or consult with your primary care doctor to ensure that they're safe to take prior to taking them. Then there's the whole set of treatment that include what can a pain management doctor do for you. And again, I think this is the next rung up the ladder of invasiveness when compared to physical therapy, non-steroidals, but these techniques can be very helpful in treating patients with back pain or back pain with nerve impingement and associated nerve-related pain, such as sciatica down the leg or pain radiating down the arm. There's two types of injections you can see on the screen. The one image on the left is an X-ray showing what's called a transforaminal epidural steroid injection. And what you're actually seeing is the pain management proceduralist is targeting a very specific nerve. So you can see this dark blush on the X-ray is a contrast dye that's injected. which allows visualization of the proposed path of where the actual medicine will go. And you can see the medicine is tracking along a single nerve route. Once the proceduralist sees that there's an appropriate blush, the contrast is tracking along the desired nerve route. They're able to inject medicine such as corticosteroids, which is a potent anti-inflammatory that can help relieve symptoms of nerve pain. And this can be performed at a single level or multiple levels. The image on the right shows what's referred to as an interlaminar injection. And instead of going from the outside in along the nerve route, as you can see on the left, this is a more central approach. By going centrally, it does carry slightly more risk than the transforaminal approach, but the medicine, as you can see, can diffuse across multiple segments. So you can actually get pain relief from injecting from an interlaminar approach across multiple spinal segments that have stenosis or compression. So this is another valuable tool. One thing that I would tell you the difference is a lot of us like transforaminal injections, or the injection on the left. The reason is it's able to target specific nerves. So if we're considering surgery or some other intervention, if you get a single level transforaminal injection and it provides substantial relief to the patient, we know that potentially we could consider doing a smaller type of procedure or surgery to affect a single nerve root rather than a larger procedure that involves multiple nerves. If you get an interlaminar injection, might provide substantial pain relief, but it sometimes gives us less information because we know the medicine is diffusing across multiple segments and affects multiple nerves. So in my practice, which we'll talk about a little bit later, if the decision is being made to pursue surgery, I'm certainly a less is more person. I think trying to do the smallest procedure with the least trauma or morbidity to the patient while providing significant benefit is my strategy. Sometimes a patient may have arthritis across multiple segments in their spine. I'm a believer that targeting what the most symptomatic nerve root is that's bothering the patients sometimes better than doing a larger surgery, which has a bigger risk of complication, longer recovery, and is a little bit more painful to recover from. Other anesthetic or pain management treatments could include things like facet blocks. Again, we discussed the facet is the connecting structure in the back of the spine that connects one vertebrae to another. This can be very arthritic in some patients and be a very robust source of pain. And sometimes a facet block or a medicine in the facet joint can provide substantial pain relief to the patient. And even following that procedure, if a facet block is efficacious but short-lived, sometimes the pain management procedures may consider doing an ablation of the facet joint, which is essentially providing a radio frequency to the nerves that surround the facet joint, which can dull pain related to that. The whole talk about pain management is its own lecture or two on their own. And I think for the purposes of treating arthritis of the spine from a surgical perspective, we'll kind of hold off on talking about other procedures such as interdiscal procedures or mild procedures, which some of you may have heard when discussing with your pain management docs. Okay, so now we're getting to the portion of the talk that discusses surgery. I'm a surgeon. I do a lot of surgery. And again, I just want to reiterate, I'm a huge believer that physical therapy can solve a lot of people's problems when it comes to arthritis of the spine. If it was me, and I had a problem with my spine, barring having significant weakness or trouble with my balance, if the main complaint was pain, I would certainly exhaust doing physical therapy and trying medications before pursuing surgery. But inevitably, some patients fail conservative efforts and end up requiring surgery, or they have muscular weakness or imbalance or bowel and bladder trouble, and they inevitably need to have a surgical discussion. So essentially, there's two types of surgery. There's traditional open surgery, and then there's minimally invasive surgery. What are the indications between a traditional open surgery or a minimally invasive surgery? And the short answer is the indications are the same. a minimally invasive surgery should accomplish the same goals as a traditional open surgery, which is in general decompressing nerves or providing stabilization and fusion of cases where there's a deformity or instability. So if you have a minimally invasive surgery or an open surgery, two surgeons you've seen for your condition, they've recommended the same procedure, but one is doing it minimally invasively, one is doing it from an open procedure. Again, the indications or the surgery should accomplish the same goals. So, in general, if you're choosing minimally invasive surgery over open surgery, just know the end goals of both surgeries is the same. It's to decompress nerves or provide stability and fusion for instability or deformities. In my practice, traditional open surgery is used for severe scoliosis or in multiple revision cases, although we are doing more revision surgery and scoliosis cases through minimally invasive techniques. In my practice, I've shifted towards more minimally invasive techniques, and these include motion sparing techniques such as artificial disc replacement in the cervical or lumbar spine, or muscle sparing techniques towards fusion, which include a combination of anterior approaches to fusion or the use of robotics and navigated CT guided navigated instruments and procedures for the posterior spine, which allows us to do the same thing as open surgeries, but through smaller incisions without traumatizing the muscle. The one difference between open surgery and what we're talking about here, you might be saying, what's the difference if they're accomplishing the same goals? The difference is with traditional open surgery, in order to access the spine to decompress or fuse or stabilize, you have to dissect and peel the muscle off of the spine. And the problem with this is that the muscle never quite heals correctly. It can heal with scar tissue. So after a surgery from a posterior open technique, the patient may have more low-level soreness or postural imbalance as a result of those muscles just not functioning properly. And in order to access the spine from a posterior approach, the incisions tend to be much larger than a minimally invasive surgery. So as a result, inevitably, you end up affecting to some degree, although it can be mild, some of the structural stabilizing ligaments and muscles for the levels above or below the areas you're working, which can lead to further breakdown of these areas later in life. So after all that, the question is why? Well, if you can do minimally invasive, muscle sparing techniques or motion preserving techniques, why are we even talking about open surgery? Well, the reason is some patients require open surgery. Not everyone's a candidate for minimally invasive surgery. Some patients with prior back surgery who need larger revisions, or patients with severe scoliosis can only be treated with an open surgery. So although in my practice, I seek minimally invasive options for my patients who require surgery, inevitably, some patients are not candidates for this and may need to have an open surgery. But again, the reason, in my opinion, to avoid this is the collateral damage associated with an open surgery. Just to kind of orient you, this is kind of a weird picture to look at, and I hope this isn't making people uncomfortable with some of the graphics of it, but this is a cervical spine. You can see this tissue here is the flap of skin and muscle that's had to be pulled off the central portion of the spine. And then this is the exposed spinal cord. These are screws and rods that are being used to stabilize the spine. So the collateral damage is, as you can see, this is a large surgery with peeling off the muscle. It results in longer times in the OR. You can have increased blood loss. There can be increased pain. And oftentimes the patients are slower to mobilize when compared to a minimally invasive surgery. So avoid open surgery if you can, but it's certainly a necessary technique. I will also tell you this, I don't want the conversation here to be that open surgery is bad. We have a lot of very well reputable surgeons in our community and other practices who don't do minimally invasive surgery. They only do open surgery, and they help hundreds of people throughout their careers. They do very good surgery. The patients have excellent outcomes. So I don't want people thinking that open surgery is a bad thing. It's just a different way of doing it. And anecdotally speaking, in my practice, my patients seem to recover a little bit quicker when they've been given a minimally invasive option. So yeah, one more graphic here kind of explaining why patients would need an open surgery. You can see in this picture here, the patient has had a prior laminectomy. Laminectomy is the technique that is used to decompress the spine, and I actually perform laminectomies quite often. It's a very successful surgery to relieve nerve pressure in certain indications. But this patient has had the lamina removed from this segment at the top of the spine all the way down to the bottom. And the reason I know that is this is C2, and I can see the lamina is still attached. And this is C7, and I can see the lamina and spinous process are still attached. In this area here, it's a bald segment. So I know the surgeon who performed this procedure removed the lamina here. As a result of such a large laminectomy across multiple segments, the patient has developed this forward pitched posture, which we refer to as kyphosis. Because, because this is A, revision surgery, and B, requires multiple segments to be stabilized and corrected from a deformity standpoint, this patient only could be treated with an open surgery, as you can see in this middle picture here. And the x-ray shows how they've had rods and screws placed from the top of the spine all the way down to the bottom segment, as well as these little interbody spacers that are intervening in the middle here. So again, open surgery is a necessary technique in certain patients. So what are the indications for minimally invasive surgery? And as I said, the indications for minimally invasive surgery is the same indications as open surgery. It's to perform decompression of neural elements or stabilize instability or correct scoliosis. It's just a matter of if the patient's anatomy and comorbidities allow the patient to be, sorry, I don't know what happened there. I apologize. So yeah, it just depends on the patient factors. So as you can see, this is an image showing an incision for a 2-level decompressive surgery. The incision's about 1.5 centimeters long, and we're able to perform through very small incisions, either using tubular dilators or other types of retractors. We're able to decompress 2 levels or more of nerve roots that are under pressure from arthritis through a relatively small incision. So yeah, we do minimally invasive fusions for cases of instability. Instability is a condition called spondylolisthesis, where you may have heard of this before, where it's one vertebrae slips forward compared to the next one, and it can result in damage to the disc and back pain as well as pressure on the nerves. And this can happen for a multitude of reasons. It can be arthritis driven. If arthritis affects the disc and the facet joints, there's a lack of stability and the bone can start to translate forward. It can be a result of an old fracture that someone has sustained playing sports when they were younger. And of course, it could be from an acute trauma or tumor or from a congenital defect. So traditionally, we used to treat scoliosis with an open surgery. And from an open perspective, you can see the curvature on this image here. This patient would have an open procedure, likely from the top of their lumbar spine down to the lower part of the lumbar spine. But now by techniques addressing specific areas of maximal deformity or maximal nerve pressure, and we'll kind of leave those areas that are less affected alone, hoping to give the patient a maximum benefit with a smaller procedure. So I want you to keep this image in mind here. This is the scoliosis, and this was the procedure to correct. We did a minimally invasive, and this is the image here is showing what's called lateral interbody fusion, lateral lumbar interbody fusion. And I'll explain what we're seeing here. This is the vertebrae, and then this is the other vertebrae. And just to kind of go back one slide, it's hard to see, but the vertebrae, because of arthritis and scoliosis, have collapsed one on top of the other. So what we're able to do is make a relatively small incision on your flank or the outside part of your abdomen. We don't cut any of the muscle. We dilate through the muscle, which decreases pain and trauma to the muscle. And then we place two, which is this gray structure here, right along the spine. This allows us to access the disc specifically. We're able to remove a large portion of the disc or most of the disc in its entirety. And in its place, we place this cage. I don't know if you can make this out, but there's this clear area here with these two lines. This is actually a medical grade plastic cage. There's one at this level and one at the other level. And this cage is actually serving multiple purposes. The first is it's increasing the interdiscal height or increasing the space between the vertebrae. And as we talked about before, that is serving to correct the scoliosis. You can see the spine is actually much straighter after these cages have been placed. And also increases the vertebral body height, which we learned before when the disc degenerates, the vertebrae get closer and it causes narrowing of the spinal canal. So these cages, by increasing the height between the vertebrae, are actually relieving the stenosis or pressure on the nerves. And the final thing these cages are doing is they're actually stabilizing the vertebrae and providing a very large surface area for fusion or allowing the vertebrae to grow together. So this is a technique we perform all the time. It's quite successful in treating scoliosis or cases of instability. This is a picture of the cage. It's actually quite a large cage. You can see these windows in here. So it's made out of metal. This one specifically, these windows are where we're able to place bone graft. The bone graft is what helps the body heal or fuse one bone to the other. So this is just a pictorial of what this cage looks like that's placed through this lateral lumbar procedure. So these are the typical anterior procedures to the lumbar spine or anterior access to fusion of the lumbar spine from a minimally invasive approach. And there's a lot of ALIF, OLIF, XLIF. What does all this mean? So LIF means lumbar interbody fusion, and the X and O and A refer to the specific part of your abdomen that you're performing the procedure. So X refers to extreme. I don't like saying the word extreme. It's actually just lateral. So this is directly across your flank, which would be right on your side here. And again, that's the picture we saw before where we're able to dilate through the abdominal muscles without cutting them, access the disc, remove the disc, and place this cage, which is what you see is happening in this pictorial. The oblique approach, the oblique approach is actually going through an incision that's not directly on the side here, but more on the front here. And that allows us access to the disc, again, not cutting through the abdominal muscles, but dilating through them. You can see in this pictorial, the surgeon has placed a tubular dilator down onto the disc in which you're able to remove the disc and place a cage. And finally, ALIF or anterior is the most frontal approach. We're able to access the bottom two discs very reliably. Typically, this procedure is performed with a vascular surgeon who's skilled in helping spine surgeons perform this procedure. These these pink structures here are actually the blood vessels. So the spine surgeon and the vascular surgeon will gently move the blood vessels, protect them, and we're able to access the disc structure, remove it, and place large cages that stabilize the bones and increase interdiscal height and correct deformity. So very powerful technique to access the disc without producing a lot of trauma to the muscle. So just like in open surgery, we sometimes need to stabilize a spinal condition with rods and screws, as you can see here. And again, through traditional open surgery, if you needed to place these 4 screws, it would be through a large midline incision. You'd have to peel the muscle off. However, through minimally invasive techniques, either using CAT scan with robotics or navigation or X-ray guidance, we're able to place these screws through very small incisions. And again, we don't cut the muscle, we dilate through the muscle because the navigation or X-ray lets us hyper focus or pinpoint the exact location where the screw can go in. So oftentimes these 2 screws can be put through an incision that's less than a centimeter or a centimeter and a half in length. So we're able to perform powerful corrections and stabilizations of spine through very small incisions. This is a picture showing what this lateral technique looks like. As you can see, the incision is fairly small, and through this quite small incision, you can access one, two, three, or sometimes up to four different levels of lumbar discs through this incision. So even though the incision is small, it allows multi-level access to multiple areas of the spine that may need work. And again, the counter to this is if you were to access two, three, or four levels from an open posterior approach, it would be quite a substantial incision that probably would run the length of most of the lumbar spine. So you're definitely avoiding a lot of muscle trauma by doing these techniques. So indications for lumbar fusion, these include things like neuroforaminal stenosis, central stenosis, scoliosis. Typically, I will try to keep my scoliosis corrections from a minimally invasive technique to 50 to 60 degrees. Sometimes beyond this, we will do a open procedure. And then of course, spondylolisthesis. So we'll go over a few of these. So you probably have all heard about neuroforaminal stenosis and probably wondering what exactly is the neuroforamen. So the neuroforamen, or the foramen as we call it, is the tunnel with which the nerve will leave the spinal canal. So you can see this is a neuroforamen here. It's this large white area. That dot is the nerve. This is a very normal open neuroforamen. You can see this is a neuroforamen that's been collapsed as a result of spondylolisthesis, or forward slippage of this L5 vertebrae. And on top of it, the disc is collapsed. So the bones have gotten closer together. So how I know this is narrowed or has stenosis is there's this big dark blob in here that's pushing on the nerve, which is right there. I'm going to try to skip through this a little bit quicker just because we're running out of time here and I definitely want to answer some questions. So again, this is treating scoliosis. This is a patient of mine who had inner body fusion from a lateral approach. We were able to place these cages through a very small incision at 3 levels. And then we use robotics to place these minimally invasive bone screws to correct the scoliosis. As you can see on the image on the left, there's a fairly significant 40-degree curvature, but after our minimally invasive scoliosis correction, the spine is relatively straight. So again, another powerful example of how we can treat scoliosis and other spine conditions through less invasive techniques. This is what spondylolisthesis is. This is the L4-5 spondylolisthesis. You can see this is the L4 vertebrae. Because of arthritis, this bone is forward translating towards the abdomen. This area here is the abdomen compared to L5. And this can create back pain, or if it translates forward, it can narrow the spinal canal and create symptoms of nerve compression, such as pain shooting down the leg with numbness, tingling, and weakness. And this is just the treatment of a spondylolisthesis case through lateral interbody fusion. As you can see, there's essentially bone-on-bone collapse here in this area here, but after the interbody procedure, there's significant separation of the bones. There's restoration of the vertebral body height, which increases the space around the nerves and decreases the patient's pain related to nerve compression. This is an incision. I would actually say this is a slightly larger incision, but typically you can see it's from the tip of this person's finger to their second knuckle here. So it's a relatively small incision that we're able to perform powerful corrections of deformities, stabilize spondylolisthesis, and take pressure off the nerve. So the whole point of these procedures is to perform what's called indirect decompression of nerves. Traditional open surgery decompresses nerves by performing a laminectomy. And as I mentioned, I perform laminectomy all the time. It's where you remove the posterior arch of bone that surrounds the nerves and gives the nerves a chance to sort of inflate into that space you've created. But this again requires an incision with muscle dissection. There's a risk of nerve damage because you're directly looking at the nerves and you're looking at the nerve sac. So there's always a risk of getting a spinal fluid leak by injury to the nerve sac. Indirect decompression is how we take pressure off the nerves from doing these minimally invasive techniques. So we're not actually looking directly at the nerves when we do these techniques. We're relying on those cages that we're talking about to increase the height between the vertebrae, make the canal height more normal. And by doing this, we're able to take the pressure off the nerve. So as you can see on this image to the right here, this is the pre-surgical image. And you can see the disc is collapsed and there's a bone spur here at the L3-4 level. And in this area here, there's a kink or areas of stenosis. This patient's MRI afterwards, from after they've had the interbody procedure, you can see the spinal canal is much more patent. Before it was 2.2 millimeters, and now it's quite open at 8 millimeters, so a substantial difference. This is another powerful MRI showing what indirect decompression can do. So this is another patient of mine. They've had spondylolisthesis at the L4-5. This image on the left and this image in the middle are the two preoperative pictures. You can see there's a dark area here. The disc is degenerated, the bone is slipping anteriorly, and there's a kink here. Similarly, the spinal canal, this is the cross section or the axial view. And what we're looking at here, this central area is the spinal canal. And because the vertebrae have slipped, the spinal canal, which contains the nerves, is this very small triangular area. And you can see the nerves are substantially crowded and under pressure. I performed a lateral interbody fusion on this patient. And if you look at the postoperative picture here, you can see the vertebral body height is substantially increased. There's less pressure or kinking in the spinal canal in this area. And I think comparing these two images is the most powerful. You can see from being a small triangular area with lots of crowding of the nerves, the spinal canal in the same area is quite open. The nerves are spread out. There's more room to breathe. So indirect decompression, not needing to perform a laminectomy, and the risks associated with it can be quite powerful. So just kind of to sum this up, traditional versus open surgery. Open surgery versus minimally invasive surgery. Minimally invasive surgery can lead to shorter operative times with less anesthesia. There could be less blood loss and trauma to the muscle. There can be shorter hospital stays because the patients typically initially have less pain and they can get out and mobilize and walk sooner. One thing I do want to explain is if you compared two patients who had the same type of surgery, one performed from an open procedure and one performed from a minimally invasive procedure, their outcomes at 1 year are the same. So open surgery does get really good outcomes. It's just getting there takes a little bit longer because of these issues we talked about. The reason I like minimally invasive surgery, even though the outcomes are the same as open surgery at 1 year, it's because the recovery period is less morbid for the patient. They have less pain, they require less pain medications, and they're walking longer distances quicker. So that's why I perform minimally invasive surgery when the patient's anatomy and comorbidities allow me to do so. We're kind of going to rush through this. This is anterior cervical decompression. The same concepts are similar to the lumbar spine. We kind of discussed this MRI slide. There's disc collapse and bone spurs causing narrowing. What we do through anterior cervical discectomy procedures, we make a small incision on the front of her neck. The reason it's less invasive is we don't cut any muscle. We're able to access the disc through the front, through this corridor here. We're able to remove the disc directly by visualizing it with microscopic techniques. We're able to remove these bone spurs by directly visualizing and removing them. And then once the disc is removed, we're able to place this spacer in, which stabilizes the area and also increases the height between the vertebrae. And then we subsequently will fix this with a plate and screws. This looks a little bit crazy. I understand this, but these instruments are quite thin, small, and low profile. And you can see this patient, they have these very large cages, which increases substantially the height between the vertebrae, which creates less pressure on the nerves. So this is a case that I did. You can see again, the preoperative image. This is another side view sagittal. There's a disc degeneration and kinking at each of these areas here. And then afterwards, you can see the kinks have gone away after we've performed the anterior cervical discectomy, removing the disc, decompressing the nerve roots, and placing these stabilizing cages, as well as plates and screws in place. It's not a very painful surgery. Most patients can go home the same day or spend one night in the hospital. And it's very effective in decreasing neurological symptoms from cervical bone spurs, such as numbness and tingling or pain radiating down the arm. And in some cases, if there's spinal cord compression, patients can have symptoms of gait imbalance dexterity changes in their hands, such as the hands not functioning well. They can notice a change in their handwriting, or they have trouble with using a fork and knife. So very effective procedure for this. A more novel, modern technique is disc replacement. We're talking not new, a few years, we're talking new, like over the last 20 years. And I actually perform maybe more cervical disc replacements than disc fusions. Disc fusion is the tried and true gold standard, is an excellent procedure, but in younger patients with less arthritis and only 2 levels or less of pathology, you can consider doing a disc replacement. It's FDA approved for 2 levels, and the studies have shown equivalence, or it's just as good as doing anterior cervical discectomy procedure out of 10 years. It's very cost effective at 7 years. And as we know, with blooming and blossoming costs in our healthcare system, anything that can reduce a cost is beneficial to us. Now, the reason to do a disc replacement versus a disc fusion is they're both essentially performing the same procedure. Instead of putting in that graft that locks the bones together, you put in a graft that allows motion. If a patient has a 1 or 2 level fusion versus a 1 or 2 level replacement, I don't think the patient necessarily feels a difference in their motion. But the reason is, if you perform fusion at 1 or 2 levels, those levels do not move, and therefore they don't transmit shock or absorb shock or traumas to the neck. So what happens is, in a fusion, the level above and the level below can start to get degeneration because they're taking more pressure. If you have a disc replacement, those levels move, they're able to absorb some of the shocks and traumas, so it lessens the adjacent level degeneration and breakdown and future need for surgery at those levels. But again, just remember, not all patients are candidates for cervical disc replacements. So where most patients are candidates for ACDF, or anterior cervical discectomy and fusion, a much smaller subset of patients are not candidates for this. And there's also a lot of geographical differences between this, depending on where you live. I'm talking, nationally, some surgeons in certain regions of the country aren't even performing this procedure. And then this is lumbar disc replacement, again, approved for up to 2-level disease, usually in patients with milder arthritis and degenerative conditions. It has not caught on quite to the same degree as a cervical disc replacement has. And I think the main reason is this: the forces that are exposed to these joints are much higher in the lumbar spine. So in the neck, obviously, your cervical spine is holding up the weight of your head, so there's a lot less force on the implant. But in the lumbar spine, the weight of your body is producing forces on these devices. So I think that's why there hasn't been as widespread adoption in my practice. This is typically a younger patient with less arthritis who is a candidate for this. Some contraindications to lumbar disc replacement include history of infection, having prior surgery, if you've got a metal sensitivity to these conditions. Obviously, you don't want to perform a motion preserving technique on a patient who has instability, because you're just going to worsen the instability. And then we've talked about the facet joints being arthritic. If you have the facet joints arthritic and you have a lot of facet joint mediated pain, just a reminder, the facet joints are the stabilizing structures that live in the back of the spine here. If you perform a replacement, the facet joints will still move, and that bone-on-bone pain can still produce pain. So we typically avoid facet joints. We typically avoid lumbar disc replacements in patients with significant facet joint disease. All right, finally, we kind of briefly touched about this. I've adopted robotic navigation into my practice when placing posterior instrumentation, such as screws for stabilizing procedures. We do a lot of these either with X-ray, CT guided placement intraoperatively, or navigation with robotics. This is a picture of me using the robot, and the way it works is we'll obtain a CAT scan of the patient's area of interest, typically the lumbar spine, and then we're able to take the CAT scans, input it into the manufacturer's software, and then I, as a surgeon, can plan perfectly the exact location of screws within the bone with pretty significant accuracy. And then we're able to take this CAT scan, and input it to the robot at the time of surgery. So what you're seeing here is me. I'm not staring into space. I'm actually staring at a screen that looks just like this. This screen is showing me real time on the patient's body where the instrumentation is going. Is it going into the right spot? This increases the precision and accuracy of doing these types of procedures. In my hands, the indications for this are patients who have scoliosis or with difficult anatomy. The one thing to note is the robot does a lot of the work, but the surgeon still needs to be skilled and have experience doing non-robotic surgery as well as robotic surgery, because as we know, not everything is perfect. There can be errors in the robotic plan, or the robot itself may have an error, and it's up to the surgeon to realize that an error is occurring and not place screws in a place they shouldn't be. So that's where the surgeon's experience with all your senses. What does the screw feel like going into the bone? Does the trajectory look normal? Is it adding up to my plan? Surgeon needs to be able to make on-the-fly decisions to avoid causing any complications related to robotics. But I'm a big proponent of robotics and use it quite often. This is just another quick case here before we get to questions. This is that other view. This is me looking at the screen. It's showing me exactly where the screw is going in that I'm placing. This is a case, again, where I've treated a scoliosis. You can see the lumbar curvature. I initially performed through a very small incision, lateral fusion. You can see these cages here that were placed at the L23, L34, and L45 segments, which performed a lot of straightening of the spine. One thing also to notice is there's bone-on-bone arthritis on the left side of this patient at each of these levels. The discs increased the height between the vertebrae, and this resulted in direct decompression and relief of patients' pain related to stenosis. And then this is me using the robot through very small puncture incisions without cutting the muscle to place these screws in. So again, if this was an open procedure, the incision would have probably started way up at the top of the lumbar spine, all the way down to the bottom of the spine. So we're able to save a lot of muscle trauma to the patient by doing this. All right, so again, in conclusion, my practice is a focus on minimally invasive surgery. I should say my primary option is to try to get the patient to get better without surgery with injections and physical therapy. Those who require surgery, it's a focus on minimally invasive surgery, limit the scope of the operation, try to do the smallest thing possible for the patient, limit the need for blood transfusions, speed up their recovery time, decrease their operation rate, and limit patients' need for opiates because they're in less pain. But let's not forget, we have a lot of doctors in our community who do excellent work with open surgery. And in my cases, they are necessary for larger surgeries, but try to limit collateral damage to the muscle and some of the other tissues. And I think that's it. I know that was kind of a whirlwind, and I appreciate your patience here. It's just a lot to talk about in an hour, but let's see if we can get to some questions here. All right, let's see here. Okay, this is a good question. So what would you address? What can you address? What could be done about the onset of adult scoliosis? Can you do anything to make it from getting worse? So the short answer is no. You can't radiographically make scoliosis progress slower or slow down or stop. And the reason is this is just the way the patient's body is aging. It's their genetics, it's the environment, it's gravity. I think that's where keeping your core and your back as strong as possible to support the scoliosis can have patients lead healthy, pain-free lives and be quite active. So just because you've got scoliosis doesn't mean you're doomed to pain. I think most patients with scoliosis can lead very functional lives, and it's about just keeping your body strong, fit, and flexible. Let's see, here's another question. How long do injection blocks last? Great question. And I get asked this every day, multiple times a day. The short answer is, I don't know, right? Like this is a medication, it's steroid medication, which is temporary. So some patients can get years from one injection, and some patients don't get more than a day or an hour from injections. But I definitely think it's worth a try if it means you can avoid trying surgery. Okay, are balance issues from cervical issues or can it be from lower back issues? So, yeah, they can be from both. There's a big difference between these balance issues. So, a cervical balance issue is the patient feels incoordinated. It's not necessarily weakness, but the patient feels incoordinated or off balance. They feel wobbly, they walk and feel they need to reach to support themselves or brace themselves or from falling. They often need canes or walkers. A lower back issue typically can cause imbalance, but it's more secondary to nerve impingement, which produces muscle weakness. So there's definitely nuances to imbalance issues that are different between the cervical and lumbar spine. And of course, people can have balance issues that aren't related to your spine at all. It could be due to your vestibular system or something else neurological going on that has nothing else going on um, with the spine itself. Okay, what comorbidities might inhibit minimally invasive surgery? So another great question. So generally speaking, if the patient is too sick or has uncontrolled diabetes or has extensive cardiac history, et cetera, they're probably not a good candidate for any surgery, but specifically for minimally invasive surgery, focusing on your lower back. Sometimes, and this isn't true for all patients, but previous pelvic surgery that's not related to your spine or intra-abdominal surgery can increase the difficulty of performing these procedures, or sometimes the patient's vascular anatomy, the location of their blood vessels in relation to where the spine is and where your incisions can be a prohibiting factor in doing minimally invasive surgery. Sorry, I'm firing through these, just trying to get to as many of these as I can. I don't perform radiofrequency ablation. I don't perform pain management procedures, but I have very skilled and expert pain management colleagues who I can refer you to. Always happy to have you come in the office and talk about that. All right, let's see. What else do we have here? We've got, how are cages secured? Okay, great question. So sometimes cages are secured by placing anchors through the cages in the bone, but a lot of times cages are secured by placing the screws through the back. So the cages are actually wedged into the bone, and the ligaments that surround the disc space serve to compress the disc and hold it into place. And the bone screws we put in posteriorly hold them in place as well. So there's a lot of different mechanisms, but I think you've hit a great point. Yeah, you're putting these cages in me, but what prevents them from going out? And there's a lot of different strategies or techniques to keep those cages stable and prevent them from dislodging in your spine. Okay, can you inject directly into the disc to expand it? The short answer is no. I don't think our technology is there yet from a synthetic or biological perspective, but certainly at some point in the future, they may we may have this technology, which, you know, I think anything that kind of is another step beyond before surgery is a great idea. Let's see, is unstable spondia L3-4 and L4-5 candidate for minimally invasive fusion? These are some of my favorite patients to treat with minimally invasive fusion because they do so well getting their spondylolisthesis stabilized and take the pressure off the nerve. So yes, high level thinking here, most certainly a candidate for minimally invasive fusion procedure. But again, that's where the patient factors come in. What does the anatomy look like? What are the comorbidities? What are the prior surgeries? All right, let's see what else we've got here. If there is disc slippage, can it truly be ever fixed? Is surgery the only option aside from living with it? Well, a majority of people can live with physical therapy and injections with the disc slippage, but those patients who can't and their quality of life is suffering, their activities of daily living are really being hampered by this. Realistically, the only way to treat this is with surgery. But again, this is a discussion between the patient and the surgeon. I never tell a patient they need a surgery unless they've got weakness or there's some really serious neurological problem. Otherwise, the discussion with me and the patient is, can you live with it? Are the non-operative things working? Is it affecting your quality of life? Are you thinking about it constantly? Is it keeping you from being active? And if the answer is yes, then you should consider, it's not you need surgery, it's you should consider surgery. Okay, can you speak to spinal stenosis and how do I know when I'm truly ready for a laminectomy? I think I kind of just hit on this. It's is your nerve pain so severe that you are getting dysfunction from it? Again, is your quality of life suffering? Are none of the other interventions working? Is it keeping you from being happy, finding joy in life, and doing things you want? Then yes, you're probably ready for um, a spinal surgery to correct that. Yeah, nothing. Someone saying, "Can you slow down arthritis?" Not yet. Whoever figures how to slow down arthritis is going to win a Nobel Prize and be the one of the most famous people in the country. We're not there yet. Let's see. Average age of the patient. This is a great question. Is there a maximum age for surgery? The short answer is no. I think most spine surgeons start raising their eyebrows when the patients are over 80. Have I done surgery on 80-year-olds, mid to high 80-year-olds? Absolutely. And this is where like there's an 85-year-old who has a bad spine condition and looks like they're 55, and there's an 85-year-old who was a smoker and a diabetic and looks much older. So there's two different older people. One is a candidate, in my opinion, and one is not a candidate. So again, it's hard to answer some of these questions with hard yes and no answers. And I think that's where like looking at the patient and listening to them and understanding where they're coming from can be the most beneficial. Okay, I love this question. Is Pilates advisable for a person with spinal arthritis? I love this question because I do a lot of Pilates for my own back conditions. So I want to say something here about this. It's really important. Yoga and Pilates are good for your core and your back. Yoga and Pilates are not good treatment for back and spine conditions. What I mean is, if your back is hurting and you have ongoing back issues, I would not recommend doing Pilates or yoga to treat a spinal condition. If you have arthritis in your back and you've once had back problems, but you've worked through it with physical therapy, you're feeling stronger than ever, and you want to maintain your good feeling back, that's where I think Pilates can be beneficial in maintaining core strength, back strength, and flexibility. So, not a good treatment, but gentle Pilates can be a good way to help maintain things. Of course, you can hurt yourself doing any activities, and make sure you consult with, someone who knows how to make sure your techniques are okay while doing the Pilates. Okay, if a screw or cage breaks, can it be left in there? Short answer is yes, depending on where the location is. So if it's in a place where it's going to cause injury to a very vital structure, then no. If it's embedded completely within the bone and isn't moving, then it's probably okay. But again, that's something where like an x-ray and a consultation is probably better. All right, this is a really good question. If you have osteoporosis, can the cage screws cause damage to the bone? The short answer is yes. Hold on one second. Okay, the short answer is yes. It's definitely a little bit more nuanced to treat a patient with spinal implants who have osteoporosis. Obviously, the risk of fracture is much higher, and I think patients with osteoporosis are often having spine surgery. Just because you have osteoporosis doesn't mean you can't or should not have spine surgery. It's just probably beneficial to optimize your osteoporosis treatment with medications, either through your rheumatologist or primary care doctor. So just because you've got osteoporosis doesn't mean you're not a candidate. It's certainly something for a conversation with your surgeon. And I'm being told, unfortunately, that our time is up. There's a lot of great questions here, people. I mean, I wish we could spend more time answering this, but again, I'm more than happy to see any of you in the office and kind of discuss any of your issues. So feel free to make an appointment. But I hope this was at least helpful and you guys kind of got a sense of, what my philosophy of doing surgery is, or how less invasive surgery technique can help you.
Thank you, Dr. Feuchtbaum, for this amazing lecture. I hope everybody was able to enjoy it. If your questions were not answered, please feel free to schedule an appointment with Dr. Feuchtbaum. He is fantastic. He is available at our locations. We will be sending a follow-up email regarding this recording, where to schedule your appointment with Dr. Feuchtbaum. And if you have any questions, please feel free to email me. Have a great and fantastic night, and thank you, Dr. Feuchtbaum, again. Bye, everybody.
Yeah, thanks to you all. I appreciate you all taking the time to listen. Have a great night.
Have a great night.